November is National Hospice and Palliative Care Month, and I am joined today by Dr. Eric Bush, who's the Chief Medical Officer for Hospice of the Chesapeake and Chesapeake Supportive Care. So Dr. Bush, thanks for coming via Zoom and taking some time to talk with me today.
Oh, thanks for having me here. I appreciate it. Appreciate the opportunity.
So what I think in honor of the month that it would be really helpful for people to understand is focusing on that critical, serious, life-limiting illness and sort of the journey of that, and how supportive care and hospice play into that journey. So my thought is, let's start with some of those illnesses. If you can talk a little bit about when someone's diagnosed with something that's considered serious or life-limiting, what are some of those illnesses?
Sure. So some of those illnesses can be congestive heart failure, chronic obstructive pulmonary disease or emphysema, dementia, Alzheimer's, Lewy body disease. Now, those aren't necessarily terminal when they're first diagnosed, so they're unlike cancer in that sense. But generally speaking, what you can think of is the higher the number, as well as usually the further down in the alphabet the letter is, that combination or either or is typically an indicator. So for example, with Alzheimer's disease, there's an assessment scoring system called the FAST score. So if you have a FAST score of 7A, we know that you have bowel and bladder incontinence, as well as a vocabulary of 6 words or less. That is considered severe dementia versus, say, an earlier stage, say somewhere in 6, where patients are still getting around, they're still continent of bowels and bladder, they still have reasonable vocabulary. Heart failure is another good one. There's several different staging systems. So there's a New York Heart classification, which is based more on functionality. And again, similar to cancer, if you have a stage 4 heart failure, that's more severe than a stage 3. There's also the American College of Cardiology or American Heart Association, which have a letter for their grades. And again, a C is less severe than, say, a stage D. And then, with cancer, what typically people think of is stage 4. So if you have stage 4, that is an advanced cancer. Although if you have a late stage 3, that is also very advanced. And so, and actually in 2017, a group of societies, the National Comprehensive Cancer Network and the American Society of Clinical Oncology, both recommended that any cancer patient with a newly diagnosed late stage 3 or stage 4 cancer should be referred to palliative or supportive care at time of diagnoses. The reason that statement was made is because we know that those patients live not only better from a qualitative perspective, they actually live longer from a quantitative perspective. I've been fortunate enough to have been able to partner with other cancer doctors and sharing patients that I've had who have been diagnosed stage 4 that have been with me now for 7, 8, 9 years. And that's, great when you could provide that quantity as well as that quality of life.
So all that information that you just gave to me, that's overwhelming. I can't imagine what that's like to be given that diagnosis, and especially if you're not, this is you talking from a medical perspective.
Right.
Me as a lay person who doesn't, it would be hard to absorb all of that. What are some things, if someone does get that alphabet of letters, the number, the staging, gets all that information, what's something initially that someone should do? It sounds like get in touch with a supportive care provider.
Absolutely. And so first is to ask questions. So whether you have a physician or a nurse practitioner that serves as your primary care provider, or if you're receiving this diagnosis from a specialist, ask questions. And if your doc, has time limits on appointments, which I understand given how busy they are,
Right.
then schedule a separate appointment or schedule a telemedicine visit and have your loved ones with you to drill down and see, doc, what does this mean? What does this mean to me? Is this going to limit my life expectancy? What does this mean from a quality of life perspective? Are there other specialists that you're going to refer me to? What is their role in my care? Because there's some diagnoses, say like chronic kidney disease, which a lot of people have. Chronic kidney disease, stage 5, if you're a stage 5, that's someone who is either going to be on dialysis soon or should strongly consider it. And, there's a lot that just comes along with that particular diagnosis, just like you indicated with the other ones. So it's so important to ask questions. And if you have someone in your family who's a healthcare provider themselves or has some healthcare literacy, get them to advocate for you. Try to schedule an appointment when they can be there so they can ask the pertinent questions to your health.
Yeah, I think that's so key. And I especially appreciate your suggestion of having another set of ears there for the appointment, or just because it is from an emotional, I'm guessing, standpoint, a lot to absorb, and you don't probably hear half of everything that's being not only is it terminology that you're not familiar with, it's just the emotional weight of it all as well.
Exactly.
So, okay, let's say someone meets with their specialist, their primary care provider, and are at the stage where supportive care could really help. Can you kind of walk me through what that feature, what that specialist would add?
Sure. So supportive care is much different than hospice care.
Okay.
Supportive care is palliative care, and unfortunately, palliative care has become synonymous with hospice, which is just not true. So supportive or palliative care is care that can be provided anywhere in that spectrum of care for anyone with a chronic disease. Let's say, for example, sickle cell disease. I've been able to care for a lot of sickle cell patients. Again, it's not a terminal diagnosis, but it can impact from a morbidity perspective. So impact on people's quality of life and impact on those spheres such as depression, anxiety, spending a lot of time in the hospital, which is very challenging, especially these days with COVID and all that's going on with the pandemic.
Right.
So it's always better to ask sooner rather than later. The question when I educate physicians and nurse practitioners, because sometimes they still have a hard time delineating between should I refer to hospice or palliative. If you're not sure, refer a patient to palliative or supportive care. And that question, would you be surprised if this patient, it can be used for families. Would you be surprised if your loved one were to die within the next year? If the answer is no, if they've had multiple hospitalizations, if you see them declining, if you see them losing weight, if you see them functionally not being able to do things that they were able to do before, then that's someone that could definitely benefit from supportive or palliative care.
And I think the other clear distinction too that people are sometimes confused about with supportive and palliative care are the treatment options. So just because you may have had that projection of if this disease progresses the way it looks like it's going to, you think they might not be here within the year, they could still be getting any curative treatment, correct? Am I understanding that correct?
Correct. So as you know, all these things are driven by insurance coverage. At some point, there should be a palliative benefit, but for right now, absolutely, patients can still get curative care. So whether it's radiation, chemotherapy, those things, they can be on palliative or supportive and still get those things. Now, that being said, one of the reasons to have supportive or palliative care, and as I mentioned earlier, some of those patients of mine that have lived longer, is you have someone to ally with you and to pick and choose what that risk versus benefit of those interventions is as time goes on. Because that skews over time, and something that may have been beneficial for someone when they were 40 may no longer be beneficial when they're 80 and they have multiple chronic conditions that have progressed. And if you think about it, it makes sense, right? So even And good example I can give you really acutely is with COVID. Um, Mortality has gotten better already. Okay, it's not where we want it to be, obviously, but when this first hit, especially here where we are in March and April, everyone with any type of respiratory issue was getting intubated sooner rather than later. We've now found that using non-invasive measures like high flow oxygen, people actually do better with that with COVID.
Interesting.
So, that's a great example of that whole risk versus benefit. And that's really what supportive care is, palliative care is, as well as hospice. And then on the other side of the spectrum, just having had that experience as supportive care provider, doing this for 15 plus years, what it has evolved to is actually primary complex illness care.
Okay.
Over time, a lot of those patients that I've had that have been with me for longer periods of time, they've asked me personally to take on more and more responsibility, to the point where many of them have requested me and our other providers within our group to be their primary care provider, because we understand what they want from a risk versus benefit perspective. And so moving into primary complex illness care is just that. Those patients that have multiple progressive chronic illnesses, and who better than a supportive or palliative care provider that's had that clinical experience for years and years and thousands of patients to help guide that patient's journey over time. And so really the benefit for that, especially given the current environment, is to try to get people to age in place, to stay away from the hospital, to stay away from things that may be high risk, where that risk exceeds that benefit.
Gotcha.
Again, whether it's going to the hospital or any other interventions, because again, that ratio does change over time.
So then for providing primary complex illness care, would that only be for someone who's older, or is that not age specific?
No, it's not necessarily age specific per se. So, right now I actually have a gentleman that I'm caring for who is 30 years of age, who unfortunately has an advanced malignancy. And again, at this point, I am acting as his primary care provider at this time. There's a lot of moving parts. There's a lot of symptoms, a lot of pain, anxiety, depression, all those things that come along with it. So it's not necessarily restricted by age. A lot of our patients are older, but it doesn't necessarily preclude someone who's younger who meets those criteria from participating in our practice.
So tell me a little bit more regarding the providing that care and that being that primary provider. Is that done in someone's home, or is it, do we have a place where someone goes to? Tell me what that looks like.
Sure, great question. So it is provided in someone's home, because again, when you say primary care, a lot of people think, oh, you're just like the doc on and
right.
No, we're not. We're actually there to partner with those physicians.
Okay.
It's more so when patients lose that functional ability to get out, or it's becoming a challenge. It takes them an hour or two just to be able to make it down the stairs and get in the car and get to their primary or their previous primary. We're not there to compete with those primary care providers that provide traditional primary care. This is really a specialized kind of primary care for patients who are functionally more debilitated, but could still benefit, say, from preventive interventions. So, with all that's going on, flu shots. So we go out and we see our patients. We provide them flu shots because that makes sense. Because we don't want them to get the flu. We don't want them to get a serious illness that may put them at risk for other cardiovascular events like heart attacks and things of that nature, which we know can happen. So there's very much a preventive piece to this, as well as, that risk versus benefit piece that I spoke about earlier.
Gotcha. And just to be clear, all of this, the primary complex illness care is being provided through Chesapeake Supportive Care, through that program. Gotcha.
Correct. It's provided through Chesapeake Supportive Care. And again, because you and I both know one of the biggest questions we get is, hey, is this covered? And yes, we're covered just like any other medical specialty, just like your cancer doctor, just like your kidney doctor, just like your primary care doctor. Insurance covers this. One of the big differences is, again, our supportive care providers spend on average 70 minutes with each patient. And that's really, and if you think about the complexity of the patients that we have, and now that we're moving into something that has, some preventative measures to it, really you need that amount of time in order to look at the whole patient from a
pull everything
360.
apart. Yeah.
Exactly. Pull
Yeah.
everything apart. Make sure you're optimizing that risk versus benefit for all that you're doing or not doing at that point in time,
Right.
and have it move forward.
Yeah,
So.
70 minutes is just an amazing amount of time where you could really, really have some in-depth conversations. And I know with Chesapeake Supportive Care and offering those services, the team includes more than just the physician or the nurse practitioner. Can you talk a little bit about who makes up that team?
Sure. We've got a great team. We have dedicated social worker as well as dedicated registered nurse who supports the team. We also have several full-time coordinators as well as a manager who oversees, in order to make sure that communication is coordinated with the patients, their families, the referring providers, the home care agencies that we partner with. So in order to be able to do this, we've partnered with Amedisys and Bayada, who have been great partners in making sure patients can get the care, the access to care that they need at home, where they need it. Yeah.
In addition to coming in someone's home, what's happening with telemedicine? Is that option available as well?
Absolutely. And so we really leave the telemedicine option up to the patients and families.
Okay.
We do prefer to do at least the first visit in person to get a good handle on what's going on, and being able to lay both eyes and hands on a patient is very helpful to assess them. But thereafter, by all means, some people are very reluctant to have anyone in their home, given what's going on with the pandemic at this time. And we respect that. We're more than happy to do telemedicine in follow-up or a combination. Some people conversely really prefer that in-person presence, and we're willing to do that too. So really, we leave that up to the patients and families, and whatever they opt for, we can do that for them. We have several different telemedicine platforms. So if there's one that doesn't work, or some people prefer different ones, we can roll with you too there. So.
And I think the other important piece to mention is that the folks that maybe still are able for supportive care appointments that still want to go somewhere, there is an option as well for that.
Absolutely. We have an ambulatory care, supportive care center, which again, any of our primary complex illness care, primary care patients that want to, more than happy to see them here if really that's their preference. Again, really patient and family preference is what dictates the venue of care.
Right. That's really nice that there's a lot of options. So I think the other piece that I'd like to talk to you a little bit about today is advanced healthcare decisions, because when you're dealing with these sorts of intense, health issues and serious illnesses, my thought is you'd really kind of have to think ahead and make sure you're kind of looking forward and really understanding advanced healthcare decisions. Can you talk a little bit about what is that? When I say advanced healthcare decisions, what does that mean?
Sure. Advanced directives, living will, telling people the kind of care that you would want, what you wouldn't want, who you would want in charge of those decisions, should you lose capacity to make decisions for yourself medically. and to me, some of the most important things about this is really you do it for your family, your friends, out of love for them. You don't want people to second guess. You don't want to put that burden on other people. Really, if you can clearly delineate and put down in writing what you do and don't want, whether it's intubation, fluids, artificial nutrition, all those things that you think about. And especially given what's going on with the pandemic, you know, it is the right time to do so. You know, the COVID thing is so crazy. There's no way to predict who's going to get sick, who's not going to get sick. I unfortunately have taken care of COVID patients who younger than me, you know, and seen them pass. And it just highlights the urgency to do so. And again, make sure your family and friends know your wishes, what you do and don't want done. And really, you do that out of love for them and to not put that burden on them.
Yeah, and especially like you said, in these unprecedented times
Yeah.
where we just don't know what's going to happen and
Right.
who's going to be able to be accessible. And yeah, it's really important
Right.
to
Right.
think about that. I know if we're running out of time, I don't want to take up too much of your day, but if you can just mention a little bit about the difference between, or the importance maybe, of having a MOST form or that medical form that people need, and just kind of talk about that versus the bigger, you know, advanced care planning that somebody might have said, oh yeah, I've taken care of that, I met with my lawyer. I think there's sometimes some confusion between those two pieces.
Right. So, great question, great point. And you do really need both. So here in Maryland, there's the medical orders or Maryland orders for life-sustaining treatment, generically otherwise known as PULSed or physician orders for life-sustaining treatment, you know, nationally. What it is here in Maryland, the front page asks about who the decision maker is, whether it's yourself, your advance directive, and what your wishes are for resuscitation and intubation, whether, you know, you just want to be peaceful when God calls you home, or if you want to be intubated and want chest compressions. And then on the back side, there's a myriad of options regarding dialysis, antibiotics, fluids, things of that nature. And again, you know, these are things that are important to take the time to do. There is reimbursement for this for your physician or provider separately,
Mhm.
that comes as a different billing code. So even if you can, you know, if you can block that additional time again with your physician or provider to discuss this, but that goes hand in hand with an advance directive or living will, which delineates the advance directive living will, delineates who's going to make decisions for you, what that's going to be like, what kind of person you are. And there's also some great tools out there. There's 5 Wishes, which is legally binding here in Maryland. And it has, in very, you know, easy to read terms, again, what you would or wouldn't want done. There's also things such as the Conversation Project, which helps you have these conversations because sometimes they can be very challenging, and you know, our loved ones don't necessarily want to hear
No,
about it.
it's not
Yeah.
the conversation, you know,
Right.
it's not what we're sitting down at Thanksgiving dinner, you know,
Right.
chatting,
Socially distanced.
yeah,
Yes.
socially distanced from one another and having that
Yeah.
conversation. Yeah.
So
Well,
yeah.
and I'm thinking that having a supportive care, I mean, that could be done during a supportive care appointment too, right? Like that seems like part of the package or something that would need to be discussed.
Correct. That's another subset of patients that we see that get referred to us. If there are a lot of moving parts there, if you've tried to have some of those conversations, by all means, supportive care provider, you know, often our nurse practitioner as well as social worker are great at having those conversations and helping you navigate some of those challenges.
Right.
So again, the patient wishes are observed. So.
Okay. I think the last final thing I wanted to just sort of, as we're talking about this transition of different stages, we're talking about the um, complex illness care, supportive care, and we haven't really gone too deep into hospice care. So
Correct.
if you could just touch on when would someone know? I think from my own personal perspective, it seems like that's a really hard call to make. You see your loved one potentially declining, but when you don't want to go too soon, and
Right.
from being in this position, I know a lot of people say, oh, I wish I had called them sooner. So it almost seems like, when is it the right time? Is there some sort of tidbit of advice that you could offer about that?
Yeah, so technically, prognostically, if someone has a prognosis or life expectancy of 6 months or less, but again, you want to, so say somebody who has advanced heart failure or stage 4 heart failure, and they've already exhausted several treatment options. Same with someone who has a solid tumor, say a lung cancer, and they've had several different lines of chemotherapy and they're either not tolerating it well or not getting the benefit they had hoped for. Those are patients, it's good to call hospice sooner rather than later, just because it really is the most comprehensive care at home with the most support. Unfortunately, here in Maryland, hospice is often used late. We are in the bottom third of hospice utilization in the country. Our average length of stay is a little more than half of what it is for most other states. And so really, in order for patients and families to get, and there's a lot of myths that people think, once I sign up for hospice, that's going to precipitate my demise.
Right.
Actually, no.
Quicker. I can't sign up for
Yeah,
hospice. It's going to
yeah,
make it faster. Yeah.
yeah. And, patients with non-cancer diagnoses, oftentimes we see them go past those 6 months, sometimes a year or so. But again, we're able to get them that patient and family-centered care at home. There's bereavement services that we provide for their loved ones for up to 13 months after at no charge. And again, given the pandemic, what better place than to be at home for as long as possible with the best quality as possible. And our bereavement services for loved ones, again, we can do virtual. Our Chesapeake Life Center has done a phenomenal job, virtual or small, socially distanced in-person groups. Again, we're there to meet patients and families wherever they are and try to provide them that care at home, which is really the best setting for care.
And I think the piece that you mentioned that follows with thinking proactively and getting advanced directives done is really setting your family and your caregivers and the ones you love up for success. And hospice, I think, is a benefit that caregivers and those that are actually taking care of the loved one that has the critical illness benefit so much from. That you're really, they might not even be aware of how much that support is for them, not only for the person who's going through the journey, but for the extended, those around them. I think it's just,
yeah, it's the same philosophy. If you think about it, it's really, one of the things that COVID has done is really made me think more proactively in the changes that we need to our healthcare system overall. We need more proactive preventative medicine, behavioral health, maternal care. We need better maternal care, the infant mortality rate in this country. So it's not just about, primary complex illness care, supportive care, hospice care. It's that same philosophy, because the life expectancy as well as the quality should be better in this country for all the money that we spend on healthcare. And we really need to rethink what we do overall in order to make this better for our patients and families wherever they are in the country. So
absolutely. Thank you, Dr. Bush.
Thanks, Danny.
To talk to me today.
Thanks.
Also want to be sure to thank the John and Kathy Belcher Institute for their generous support of the community education programs at Hospice of the Chesapeake.